Welcome. My name is Dr. Kesava Ramakrishnan. I'm a pediatric intensivist trained in the UK and currently working in the United Arab Emirates. In this video, we are going to discuss patient selection for neonatal respiratory ECMO. We will also briefly discuss the outcomes. This graph from the International Summary of their data by the Extracorporeal Life Support Organization, or ELSO, shows that ECMO usage has been exponentially increasing since the H1N1 pandemic in 2008-2009. In 2020, 521 centers submitted over 18,000 patients treated with ECMO to the ELSO database compared to 83 centers and 1,600 patients in 1990. This table gives a breakdown of the patients submitted to ELSO database based on age category and diagnostic category from 2010 to 2015. As can be seen highlighted in green, the number of patients receiving ECMO for neonatal respiratory failure remains stable between 800 and 900 per year over this period. However, as shown in red, the use of ECMO in adult patients for all three indications has been growing rapidly. Due to availability of better therapies such as permissive hypercapnia, high-frequency oscillatory ventilation, inhaled nitric oxide, and so on, there has been a decline in the number of patients with neonatal respiratory failure who require ECMO. This report, which compared the cohort of patients submitted to ELSO database from 1993 to 95 as opposed to 2014 to 15, showed a 33% decrease in the number of ECMO runs for neonatal respiratory failure. This reduction in numbers can be accounted for by the less need for ECMO in patients with meconium aspiration syndrome, sepsis, and respiratory distress syndrome. It is likely that these conditions may respond better to treatments such as high-frequency oscillation and inhaled nitric oxide. Both these factors have led to a decline in the neonatal respiratory ECMO runs as a proportion of total ECMO runs over time. As can be seen in this graph, in the 90s, almost 90% of the patients treated with ECMO were accounted for by neonatal respiratory failure, whereas in 2016, the neonatal respiratory ECMO runs accounted for less than 10% of the total runs. If we consider all the patients submitted to ELSO database, these 5 diagnoses account for majority of the patients treated with ECMO for neonatal respiratory failure. However, trend analysis shows that the proportion of patients accounted for by these 5 diagnoses has been declining over time. In 2014-15, these 5 diagnoses together accounted for only 83.9% of the patients as opposed to 94.1% of the patients in 1993-95. Therefore, it is likely that other diagnoses which were not considered for ECMO previously are being considered for ECMO in the current era. Please also note that patients with congenital diaphragmatic hernia requiring ECMO have significantly longer need for ECMO. Also, these patients have the worst prognosis with a survival of 51% overall. The number of patients with congenital diaphragmatic hernia and idiopathic PPHN has remained stable over time. However, now they account for a much higher proportion of neonatal respiratory ECMO runs due to the decline in the total number of ECMO runs. There has been an increase in the conditions other than meconium aspiration, congenital diaphragmatic hernia, PPHN, respiratory distress syndrome, and sepsis being treated with ECMO in the current era. Diagnosis other than the top five conditions has increased from 4.8% in 1993-95 to 14.3% in 2014-15. This trend has accelerated as shown in this report, where the diagnosis other than the top five conditions now account for 33.9% or a third of patients treated with ECMO for neonatal respiratory failure. These patients have conditions such as pulmonary hypoplasia or other congenital anomalies which have more uncertain prognosis, therefore excluded from ECMO in the previous decades. If we look at the overall survival in the ELSO database, neonatal respiratory ECMO seems to have the best prognosis with an overall survival of 73% to discharge. Looking at the trend, however, the survival for this group has been declining over time from 76% in 1993-95 to 67% in 2014-15. This is not surprising as the centers are offering ECMO to conditions with more uncertain prognosis more often in the current era. It is therefore very likely that the survival in this group will decrease over time. If we look at the mode of ECMO used for neonatal respiratory failure, we know arterial ECMO accounts for vast majority of these patients. As shown in this graph, only a third of patients with neonatal respiratory failure are treated with VV ECMO as compared to over 80% of adult respiratory failure patients. The most frequent reason quoted in the literature for this is the lack of appropriate reinforced dual lumen cannulas that can be used with centrifugal pumps in this age group. General principles of patient selection for ECMO also apply to the neonatal respiratory failure population. The baby needs to have a severe respiratory or cardiac failure from a potentially reversible etiology that is refractory to maximum medical therapy with a high likelihood of mortality. ELSO guidelines recommend these criteria for selecting out patients with high mortality who may benefit from ECMO. This criteria has not been directly evaluated in randomized controlled trials. However, a similar criteria was used in the UK collaborative randomized controlled trial of ECMO in neonatal respiratory failure between 1993 and 95 and was found to select out patients who would benefit from ECMO. Patients with lethal congenital anomalies or chromosomal disorders are not candidates for ECMO, as or patients with irreversible brain damage from hypoxic ischemic encephalopathy and so on. Patients who have grade 3 or higher intraventricular hemorrhage or uncontrolled bleeding have a very high risk of complication from ECMO that may be lethal. Therefore, there are also contraindications for ECMO. Centers also include contraindications based on local expertise. For example, if the surgeon is not comfortable cannulating less than 2 kilos, that center may choose not to offer ECMO for babies with birth weight less than 2 kilos. Similarly, expert consensus-based criteria has also been published by ELSO and the European Consortium for selecting patients with congenital diaphragmatic hernia for ECMO. ECMO in neonatal respiratory failure is usually used as a bridge to recovery. In over 80% of the patients, ECMO is weaned as the lungs have recovered. The longer the patient requires ECMO, the lower the chance of lung recovery. As shown in Table 5, only in 50% of the patients ECMO was weaned for lung recovery if they required ECMO for more than 21 days. In summary, use of ECMO for neonatal respiratory failure has been declining over the decades. Centers are offering ECMO for more complex diagnoses such as lung hypoplasia. Congenital diaphragmatic hernia has become the most frequent diagnosis for which ECMO is offered in this age group. Mortality has been increasing as a result of patient selection with more uncertain prognosis.